radial approach. His legs vessels are quite tight. I'm just doing one spider view just to show people. And Amar, Amar, did you see it?
Yeah, I see it.
I mean, his flow is okay with the vessels.
Okay, want me to mobilize?
Yes, you should mobilize the team. Fluoro? No, fluoro, yeah, good. Okay, ready? So it's a very complex plaque, and I can do it, but I think he's got flow through. What do you think, Amar? He's a surgeon over here, and he's looking at the patient flow. The right is absolutely okay. His blood pressure is now 90 by 62 and 72. His heart rate is 94, and his creatinine is normal. So I would actually opt for considering of a surgeon. 2.5? 2.5 is creatinine? So his creatinine is 2.5. Did you hear that? How much did you hear that? Okay, let's do one more test, contrast. So that's actually making it going to be very hard. I mean, this is a hard case to make a decision as to what we should do.
Omar said it's definite surgery.
Okay. He's okay with that? So the surgeons are willing to take him to surgery. I think this is a true heart team decision. We have very good flow in the vessels. We have an Impella. His LV function is actually not good. His blood pressure is he on inotropes? So he's on norepi, and he's pulling, and he's getting. How much is he getting on the Impella? Okay. Yeah, we're done chloro. Did you hear his creatinine? And he was doing well till yeah. What do you think we should do? No idea. How are you feeling now, sir? Yeah?
From the cardiologist's office, I spoke to them earlier. Julie just had to send them.
He's doing something, his pressure's going down. Yes, I'll get that catheter out of there.
50%.
Okay. Did you not go today?
Yes, I did it on the bedside only. It's low.
So it's changed.
Yeah. All right, so his pressures are okay now. I think we should.
Hydrate, complex left pain.
The patient's okay with it. Sir, we'll most likely consider you for open heart surgery. You have a very severe narrowing of your arteries. Okay?
Is it totally necessary?
If you don't make it, you will not survive.
Sounds like
How's your pain now?
4.
4 out of 10. So his pain is a little bit better. I think he's got good flow in the vessels. I just given him IV heparin. We'll actually give him 4,000 more heparin. I would take the catheter out now. So Amar, I'm going to take the catheter out. Can we give you a wire? So
Here, use this.
They're small. I mean, they look smallish to me. LED, and he needs like a Venus or a Surf. Whatever. I think basically whatever you see, we cracked. One of those. Okay. Schump. SCHUMP. Do you want to do this, and you want me to do this? How do you want to?
Okay. Thank you.
That's fine.
Is patient going to stay here and then we're going to use the line or then
No, it's okay. We can do it. No, don't cancel it. What's the time now?
It's almost 4. We have another STEMI waiting.
There's another STEMI?
Yeah.
And is the pay going to come here or there? Okay. All right.
Okay.
So we are planning to take him to surgery. He's clinically stable now. His pressure is, yeah, go in the other room. Okay. All right. So we should actually. So I think we're done in transmission over here. We're just going to close the groin is fixed. We're just going to secure the impella in the groin and send him to open heart. And open heart room is just the next room on the side. So that's a good thing. And I'm just going to take this out. Let's clamp it out. Let's cut the sutures out. Yes, sure.
What are we doing?
We're going to just secure the impella.
Secure.
This is really going to be a unique platform. People will be able to tune in and see interventional live cardiology cases from around the world performed by some of the world's best operators. The real advantage of this is that they'll do 9,000 cases spanning the whole spectrum of interventional cardiology.
For MedStream 360, we'll be extending 24-hour live cases so that you can watch cases in your own time zone, time frame at your own convenience.
MedStream 360 is a transformation in medical education. With MedStream 360, you can see wherever you are, in your office, at home, in your computer, in your iPhone or your laptop or your iPad, any case in any topic whenever you want. And not only that, you'll be able to see the best operators from around the world sharing their live cases with you.
There are several unique attributes of MedStream 360. We have no moderation and there is no time restriction. The majority of the cases, an overwhelming majority of the cases, are viewed not live but archived cases. So to enhance your viewing experience and to customize the archived cases to your requirement, we have assembled an army of physician video editors who have been experimenting with different formats. All of this is being done to enhance your experience and to make MedStream the most beneficial.
Concept here is to provide easy access to more live demonstration cases to more physicians. I think live demonstration cases are probably the best way to learn the nuances of our field. And the more we can do to bring cases of interest to our community, the better we'll all be. This is a great way to exchange information and to keep up with the latest in interventional cardiology, period.
So I look forward to welcoming you to MedStream 360, and please give us your feedback. We hope you enjoy it as much as we're enjoying putting it together. Thanks very much.
So this is a patient who was 80-year-old, had heart failure symptoms for last few months, had a aortic valve 23 millimeter perimount 2800, which was deployed in 2007. So I had a good time. I mean, 15 plus years. Got it. Patient also had multiple other risk factors, and more importantly, had a stents in the both extremities, and we'll show you those stents. Medications wise all good. Right bundle branch block, first degree AV block, and coronaries are non-obstructive. More important is from echo point of view, we'll show you the live echo. We can go to Dr. Laraka's screen, please.
Yes, good morning, everybody. So this is the mid-esophageal four-chamber view, where you can appreciate that the normal LV and RV function, mild tricuspid regurgitation. This is a long axis mid-esophageal view of the aortic valve and aorta. As you can see, very degenerated bioprosthetic valve, thickened leaflets. Here you cannot appreciate much the aortic insufficiency, but I will show you on the deep gastric views that there is aortic insufficiency as well. This is X-plane of the short axis view. Again, you appreciate the thickened and decreased mobility leaflets of the bioprosthesis.
And this is the sutureless valve, right, Gilbert and actually Farjan, which valve inside?
Perimount 2017, that
Yeah.
normal sewing ring, and you have to use sutures to anchor them to the annulus.
I see.
Yeah.
Stent frame, but anything special that this valve can be fractured, can be dilated, right?
I think they can be fractured.
Fractured, okay.
Yeah, they can be fractured.
Ejection fraction is about 50% dilated ventricle. No evidence for pericardial effusion. This is deep gastric again of the aortic valve. You can appreciate the thickened leaflets, decreased mobility, stenotic valve. Here you can see also the aortic regurgitation, moderate valvular aortic regurgitation, and mild PVL. Two jets, as you can appreciate, and these are the velocities: peak gradient of 70, mean gradient of 40. Putting all together, aortic valve area 0.7 centimeters square, severe aortic stenosis with moderate aortic regurgitation.
Beautiful.
Very distracted valve.
Question now, that when you are doing a surgical valve replacement in the age of 60, 50, 60, 70, are you considering that this patient will require tower down the road, and any special valve preference for that?
So we currently use the next generation, which is the 5th generation of Edwards valve. They're called Inspiris. They don't require preservation in glutaraldehyde. We still have to anchor them into the annulus. Our goal is actually to put the largest valve possible, so in the future the patient can get a TAVR with a large size valve. So we have a low tendency first to put large valve it fits, or to do annular enlargement in selected patients to put large size valve for the future.
So this is the transesophageal echo, which all has been shown, and CTA.
Sure. So it's a 23 perimount valve. You can see minimums around 21, which is expected, and LVOT is pretty generous. So overall, it seems like pretty benign anatomy for a valve and valve TAVR.
This is about the valve to coronary heights.
Yes. So 5.1 and 3.2, which is more than what we need nowadays. Around 2 is the cutoff. We have good generous left mains, huge sinuses. So I see no issues with coronary obstruction here.
And then this is the vascular access, seems to be okay?
Yes, very straightforward.
And what is below that arterial circular structure, right?
That's a venous stent. A patient has bilateral venous stents that were placed, but overall the arteries are pretty benign, almost no calcium.
We can go back to the fluoro 1 second to show the endovascular reconstruction of the vein.
Yes.
This is amazing.
It's amazing.
So both sides venous construction. This patient has repeated DVTs and so.
Yes.
Let's go back to the slide presentation again. So we complete it, and we go on further from the procedural point of view. So this is the 23 millimeter perimount 2800 valve with bovine pericardial leaflet sutured inside the stent, and our goal is put a evolute 26 millimeter, right?
Yes.
The valve and valve positioning. So anything concerning?
No, I think we have to see crossing, and then we are all ready to crack this valve. I think when we are ready, we'll show how we are to get the balloon and steps to crack the valve. Yeah.
Beautiful.
So we'll cross it with the AR1 that we normally like to cross. We'll show the steps to cross the valve now.
Okay. So therefore, this is nutshell. 80-year-old patient with a failed bioprosthetic valve, and the plan here is now to put a evolute FX with 26 millimeter and use of the sentinel cerebral embolic protection device. So that has been done in this particular case. We can go back to fluoro, please. And access wise, we didn't want to go through the vein, so they have the pacemaker through the neck.
Yes.
which will be left anyway. We usually try to leave it for 24-48 hours. The vascular rest of the vascular access was good. Now we are ready to. It's the AR.
AR1. I mean, normally we like LAO, but we may need to go to the RAO when we are trying to cross the prosthetic valve. Let's go to the RAO view. Let's try AR2. Otherwise, we may need a Lima or a no
V18
also.
wire. V18 wire.
It's
no.
nothing to do with
a
that.
valve and valve, V18.
No, that's not the thing. It's
Get a V18 wire.
You need the catheter assist to face the valve.
Yeah, so always is a little challenging going through the degenerated valve, whether it's a tower or surgical. So usually go with a smaller. So that's where we started with the AR1. The pigtail you have to pull back. If not, then you have a few other things. You can multi-purpose, although it's vintage.
If you have the right catheter, it just takes 10 seconds.
I think we have to give credit to AK for the RAO view that she describes. And
go.
Good.
We change it first. Then
Can we see the gradient?
No, but we'll go with the pigtail. Okay. Show the gradient now in the lower one. Put the hemodynamics gradient. Good. Very high gradient as expected. 70-80 millimeter.
Can we put the gradient in a small thing in the side?
Okay. Now we are exchanging. It's a regular or 35 Teflon wire to change to the pigtail, and then we go with the Safari.
I think this is an atraumatic way to exchange catheters. Use a J-wire pigtail.
Yeah, tell, knowing that Gilbert, you are going to various meetings and came from the TVT registry, and looks like the Landerquist wire is getting a big favor, and particularly Pro Plus. They all wanted us to use Landerquist, although we didn't use in the Evolute Pro, the Optimized Pro trial. But so looks like Landerquist wire is taking a big momentum. I know a few centers in India, they routinely use it. And what is your Gestalt feeling of the Landerquist after the TVT where you were there and had a lot of presentations?
Yeah, no, I think people, it definitely has a learning curve. As you know, it's a very stiff wire. The curved portion is quite small and it's not pre-curved like the Safari, so you have to be very careful, particularly in patients on chemo, on steroids, on very old patients. So we still have not done that, and I think, you know, with experience with the wire manipulation, I don't think you absolutely have to, especially not with the FX.
Okay, now, so we are ready to crack the valve. If you can show the ceiling camera here. So this is the balloon. This is how we are attached. So what I'm going to do is, once we are at the right spot and when we are pacing, I'm going to go up with the syringe. So when I know the balloon is fully inflated, you see the three-way stopcock, then I'll close. So we are open now, and then with the indeflator, I'll be going up fast. That's the time we will crack it.
So let's take
okay,
the
Gilbert,
out,
take the parallel. Okay, Gilbert, you good, right? Tee up, please, because I need to see when we are cracked. Yeah,
good.
It's good, right?
Yeah, looks great. Maybe a little bit deeper on the balloon because you sometimes can push up with the valve stenosis. But
okay, good.
Okay, now 180. So Sahil is holding both the hands. Okay, I'm going up with the balloon.
Beautiful.
Good. Okay, I'm close now. And now immediately I'm going up with the syringe and a long pacing run. I'm going up. Did you crack?
You
saw
see it.
You saw it.
Perfect.
Cracked. Yeah, I'm going down. And then back, previous stopcock, change,
walk out.
And that's it. Stop pacing.
Resuscitate.
Joe, resuscitate.
Valve ready.
Yeah.
You have AI.
I think we got it on the,
we can pace a little faster too to unload the ventricle.
Yeah.
Pace 80.
So this is something that our team is ready for, right? So this is kind of typical scenario. The blood pressure quite low. You just have to go quickly with the valve. So the Evolute FX, you can see
position.
that 3 o'clock.
Yep.
And they have the depth marker, which also helps with commissure alignment. Go ahead.
So that is why many people will put the valve and then fracture it. Avoid this catastrophe sometimes, although that has been debate that which one you
actually like it
please. Tee up, let's
tee up, please.
You can see that the head marker outer curve on this LAO, this is a great spot to start.
This is a great spot, yeah.
And you can see the depth marker as you come.
Hold the wire,
Yep.
Okay.
Go to the next previous view, the LAO.
Yeah, let's take the parallax out of both. I think LAO is okay.
That's good.
Perfect.
This good.
Perfect. Yeah.
Okay, good. I'm going releasing.
Go. Yeah. Pace at 120 maybe.
120 pacing.
So you can see the depth marker is a very nice position.
Sine, please, once. Good. Okay, yeah.
Excellent.
Looks good, right?
Okay,
Excellent.
now go to
80.
80. Yep.
80,
So you can see the
beautiful.
depth marker, that's a 3 millimeters.
Good.
Okay,
Okay, pressure is
Okay.
still low.
okay,
Hey,
good.
pace at 80, please.
We need a little resuscitation.
Resuscitation.
Yeah, let's
No.
take the parallax out of the evolute and see, make sure all the dots are below at the annulus, because that's important. Now we have these markers to show whether you're too high or not.
No, I think we are too high.
You have
Look
to
at
bring the
one spot. Look at one spot.
Yeah,
I
maybe-
think it is. Yeah.
Maybe okay.
We are maybe okay.
You want to bring a pigtail quickly?
No,
No,
we should
pigtail
do the.
not going to tell us.
Let's take the parallax off the evolute and see,
Floor,
because I think
floor.
right now there still looks like parallax on the
Pressure is
evolute.
better.
I think it's a little too
Pressure,
high.
yeah, pressure getting better, huh?
I think it's a little too
It is
high.
high. It is high.
I would,
That's what I'm
I would
telling.
recapture a little bit,
Yeah.
making sure the one of the because you have
Okay, see here. I'm taking the
Good.
parallax out.
We can do
right?
it in this view
Okay,
then.
good.
Let's do it in this
See here,
view.
1 second. I'm going up. See here.
It's up.
yeah you
See,
have two
see,
yeah.
see the posterior is up.
Correct, that's right. You have two dots that are above the frame.
Yeah.
I would
Okay, this
recapture
should-
this.
Okay, so go a little bit in. Okay.
Do you want me to go any other view to confirm?
I would
think
just take the
I can-
parallax cell off the evolute valve, because right now you have a lot of parallax
Some
on the
parallax.
evolute valve, so you can't see the back
Hold on.
very well.
Okay,
A little
okay.
caudal.
No, I'm seeing.
Maybe
Okay,
a little
see,
bit
this is-
caudal.
Yeah.
Yeah, there you go. Yeah, that.
No.
Yeah.
See, we are completely above the frame now.
Yeah.
I think let's try one more recapture. Go.
No,
Yeah,
we
that's
have
the
to be in the right
recapture.
view.
Yeah.
Okay. Okay, see here.
Okay. Yeah, you're too high. You see that
Yeah.
there,
Yeah.
right?
High. Yeah.
Yeah. Okay,
Exactly.
let's
And,
recapture
see,
now.
I think this is a good view for us to place, right?
Yeah, just go
Okay.
in a little bit deeper, and then you should be good. The
Pace-
depth marker is very helpful. Pace,
Pace
yeah.
150, please.
The pressure
Okay,
is
pacing,
good.
pace. Pressure is very
Yeah.
high now.
Yeah.
180 pace.
180.
Very good.
Yes, very nice.
Ah, okay, go.
80. Go to 80, please. Okay, pace 150. Pace 120.
Okay, looks great. So let's take the surgical valve. Yeah, this
Pace
looks good.
80.
Wait.
Sit there.
Let's do a Cine ANC.
Mhm.
Yeah, I
still-
think this is better. No?
Yeah.
You want to go to some other view?
Let's go to another view to look at the surgical valve. Make sure it's still
Yeah.
below the.
Let's do a little aortogram.
Yeah,
Bring your pigtail.
but but now at least two dots are below the frame. You see
Below
that?
the, yeah.
Yeah.
That's I think important to know.
Good.
That's perfect. That's great. Oh, yeah,
Looks
you got,
great. Yeah,
oh,
that
you
looked
just-
good.
right there,
Go
right there. Perfect.
Good.
That looks
Bring
great.
the pigtail down.
This one?
Yes.
Okay.
Yeah, bring the pigtail down. Let's see.
This
Little,
is,
show a little bit.
no,
still old
you don't
style.
need that.
Yeah. Pull back. Pull back. Good. Let's go.
So Dr. Sharma has a great point. So if you worry about the left main obstruction, you definitely want to do an aortogram before you release the valve, right? I mean, this case is not much of an issue, but we did fracture the valve, so it's good to see.
Beautiful.
Okay, so you see that it should be
You don't
fine.
see it.
No,
Still
but Dr. Sharma will have a good point about your cases of high left main obstruction risk and you fracture the valve. You definitely, before you commit, want to see in case you need to protect or anything. But I think it looks great.
Okay.
Okay.
Good. Release.
What does everyone
think-
think here? Yeah.
Yeah.
Just
Yes.
push a little forward, that's the hill, and you
Yeah,
want to
okay.
release.
Slow.
And I would rapid pace to release the valve.
Yeah.
Okay, 180. I'm
And the
really
wire back.
taking off.
The wire back.
Yeah.
Center
Yeah.
wire. Yeah.
Yeah.
180.
Almost
Release
there.
Not yet.
Not yet. Not yet.
Let me push.
Good.
Okay.
Yeah,
Back up
good.
80, please. Push the wire, okay?
We are-
Push.
Okay,
Hemodynamics.
okay, yeah. Okay.
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 Do hemodynamics.
Yeah,
Recap.
excellent. Very good.
Very nice. Beautiful.
Good.
And you can see the C-tab lines up with the commissural post, so perfect commissural alignment. Look at that.
Push the wire. Yeah.
Okay, good. Come out.
How does it look, Stam?
Yeah,
On echo.
Okay. Now we can advance.
very good. No AI,
Good.
valve
Can
open.
we show
Okay,
echo?
pressure is good.
Yeah.
Show the echo, please.
Good position of the valve.
Backup pacing.
Yeah, very nice.
You have a catheter still in. No valvular AI. No PVL, at least from here.
Yeah, though the fracture might have taken care of that PVL that you mentioned earlier because it expands the frame.
Yes.
So I think this is important to make a note that if you have moderate or severe PVL, that will be difficult. But mild, if you fracture, you're going to have more expansion against the annulus. But you can safely do that, and then you can also optimize the frame expansion
That's the other one too.
of the evolute valve, which I think is getting to be more and more important now. There's a Circ paper just came out on halt and frame under expansion with TAVR. So I think it's very important to optimize frame expansion now, especially with valve in valve.
This is deep gastric images. little bit PVL, as you can see. And the gradient.
And they're talking about the commissioner alignment even for self-expanding with the balloon expandable valve now. I know we have been promoting with the commissioner alignment with the self-expanding, but even for balloon expandable.
Yeah, I think everyone is going towards this feature. I think both Edwards and MyValve are working on something similar to allow that to happen. But we'll see once the data comes out.
All very good. Fantastic. So from the procedural point of view, it's optimized. Now let's say the gradient would have been 30. Then what we would have done? Go back and with the post with which balloon type? This one we used 23 pre. So post would have been what? It's a 26 millimeter evolute.
Would be 24, I guess.
Yeah,
right?
would be 24, but then the reason we try to do an aggressive pre is to avoid post in these cases, because you can have injury to the evolute valve leaflets if you're too aggressive.
Yeah, question comes if there is still the high residual gradient, what balloon we would have done? That question is, what is the usual acceptance? What we try to do, the data that you want to bring it to less than 20, which is good. This one is 8, single digit, beautiful, fantastic results. Now, if it's a 25, 30, so key is in the past, we say, well, we were happy to just do it and come out. No. If patient has a good life expectancy of 10, 15 years, your optimization at the time 0 is very important. So you need to bring it down to single digits. So you need to use a post dilatation balloon, whether it's a true balloon or whichever way, ZMAD and so. But then you probably would have used 24.
Yes.
Right? 24 or 26. Which 24. One we would have used?
24.
24.
Bigger than that could be issue.
So 24 would have been,
Yeah, so Dr. Sharma, we have a question from the audience. They asked, do you always use a Safari for valve-in-valve cases?
So very good point actually. Whether Safari versus Lenderquist, clearly we don't use Lenderquist. Just to say, a lot of people, Lenderquist is the primary wire at Mount Sinai, Lenderquist is the rear wire. We use maybe in single digits. So question is Safari versus the small cavity wire.
Yeah. So Safari, we have moved to Safari from Confida. It's very atraumatic, especially in smaller ventricles. In females, we've seen Safari is less traumatic. Lunderquist we only use in bicuspids, horizontal aortas, or if we're using a 34 evolute. That's the only cases we would resort to Lunderquist, or if there's extreme iliac or aortic tortuosity.
And Confida wire, which situation do we use Confida?
Confida, almost nothing. Almost
so there is no true use for Confida. So it is between Safari and Lenderquist.
Yes.
And till Medtronic comes with some new wire. They all have to.
But I would say with FX, really, Safari would be a workhorse wire because it's so stable and released. Because people were worried about initially Pro Plus or Pro that, it will pivot a lot. You can go deep, you can go shallow, but we don't see that much at all anymore with FX.
Okay, go on fluoro, please, with the FX, these 3 dots. So you can comment, Gilbert, on this, what these 3 dots are, which we are seeing for our audience.
Yeah, so if you take the parallax out of the evolute valve, you can see that the 3 dots represent the 3 millimeter depth from the inflow. So from a native TAVR standpoint, you can see that exactly when you do the aortogram where the dots are. Now you can see that in this particular, we end up releasing it, and you can see in a really high position, the dots are actually inside the paramount frame, but you can see that one of them is below, so this is as good as you can get for valve-in-valve. Yeah. This will be excellent hemodynamics here. And so I think this is something that's important. And these dots are aligned with the commissures. That's important. And Dr. Sharma, Dr. Kinney, and Sahil can comment about coronary access. Because when you have these dots, you know exactly where the commissures are. One of the dots lines up the C-tap. So from a coronary access standpoint, this will make it easier, I think.
And actually, I can tell you the other one. In the structural, we have a strong need or asking people about the valve-in-valve and tower-in-tower. Actually, in the coronary, there is a lot of interest about doing a PCI through the valve, with the tower valve. So, a lot of demand. So, we in the structural, in our coronary cases, our CCC live, we start doing quite a bit. There is a more request from other places also when we do live. So, key, because engaging coronaries is a challenge. Clearly, we know that with evolute is always a challenge, but even with some sapien cases is a challenge. And so, but that required a little better understanding of this valve hemodynamics, and hopefully these all the commissioner alignment and all these will help us to get a better coronary access. Okay,
Great
with that
case
note,
and great result.
with that note, is exactly on the dot we complete our presentation of today's structural case. Anu?
Well, thank you very much, everybody. Great case. World's first live FX. I think congratulations to the Mount Sinai Cath Lab team.
This is a 68-year-old male patient who presented, who had a known carcinoid disease and had the tricuspid valve replacement few years ago, and now became more symptomatic with the dyspnea, leg edema, ulcers, and found the tricuspid valve both regurgitation but more stenosis. And clearly, at age of 68, already, and patient also had developed now the liver cirrhosis. So adverse factors for reoperation, and therefore this patient went for heart team discussion. Others are shown here, the parameters, and more importantly, echo point of view. This was the echo about a month ago and so, but we can have the live echo by STEM Laracus at present, which will show the tricuspid stenosis as well as regurgitation. So STEM, for you.
As you can see, the LV function is about 40%. The patient has also moderate to severe mitral regurgitation. This is the right ventricle. The size of the right ventricle is normal. The function is maybe mildly decreased. As you can appreciate, the tricuspid bioprosthetic valve and a huge right atrium. This 3D image of you can appreciate the annulus, the ring of the tricuspid prosthesis, and you can see the thickened leaflets and the immobile leaflets as well. This is with color, mostly stenosis on this case, with maybe mild to moderate tricuspid regurgitation. This again is 3D zoom image. You can appreciate the ring of the prosthesis and the thickened leaflets, immobile leaflets. And this is the gradient. We got a mean gradient of 10 and a peak gradient of 14, severe bioprosthetic tricuspid stenosis in this patient.
This patient, high risk, as we said, suitable candidate for tricuspid valve-in-valve implantation. And So now, Gilbert, you want to comment on the CTA with the this kind of valve situation?
Yeah, the patient had an advanced CKD, so didn't do a contrast, but because this is a bioprosthetic valve that has good signature, we can measure the internal diameter, and with the valve-in-valve app, you can also see that it's going to be a 29 valve, and I think because it's a 33 paramount, we're going to go plus 2 cc.
Gradient.
So.
Okay, so 29 plus 2 cc's, and this is where it fits in. The superimposed images of inside the leaflet, how they will look. So this is basically where we are. So our plan is 29 plus 2 cc's Sapien, the Edward Paramount valve within the old valve, and now we are ready to start.
That's right. So this patient had a lead across the prosthetic valve before. So we discussed about EP colleagues. We don't want to crush the lead or cause paravalvular leak because of the lead. We decided to extract the lead. But one elegant way that our EP colleagues have done, essentially, rather than removing the generator and the lead itself, he just kind of pull it onto the IVC, which you see here in the floral. So I think it's a pretty elegant way to do it. And in fact, we try to do that for triluminate pivotal trial patients too, for those who have RV lead interfering with potential candidacy.
Okay, so that's very good. Now, tell us what are we doing here, what we are seeing in the hemodynamics.
Now, since it was a stenotic tricuspid valve, it was a little challenging to cross, but I think you can see how we have recorded that. So same, I think, how would you cross? Usually pigtail, but initially pigtail would not help us. So we had to go with the JR catheter, just with the J wire. And once you are there, you go to RAO view like we have right here. And then you make sure you're in the center of the valve. That's how you see the step, how I was getting in, just with the JR. With the JCAT.
Right atrium here is very large. And support may be a bit of an issue. When I've done these cases, I've used a deflectable catheter like a Gillis or Oscor, cross with the soft J wire, put pigtail in the RV apex, and then with the support of the deflectable catheter, I can usually then pass a Safari wire without any problem.
So if we were not able to cross with the JR like we just showed here, then our next step would have been to have the edgeless catheter. Then get into the RV.
Hey, it seems that there will be more coaxiality from the IJ, but they're always doing from the femoral. Neil?
Yeah. I think this is a good discussion point. I mean, you're going to be more coaxial coming from the femoral than the jugular, but you can do it both ways. I think for patient comfort, usually femoral is preferred. The question is this wire stiff enough to support the Sapien as a rail, because the right atrium is huge, and as we see, there's a big loop. So I just wonder if we pull on the wire slowly, whether it can become a bit more coaxial.
Are we in the apex? Can we show it on the LV? Echo.
Okay, now we have to recross again. What did you use to recross? Why don't you go with this edgeless plan?
Okay.
We go with edgeless catheter. Get your balloon tip catheter again, right? Everybody agrees on that, because this one is not giving the
No,
support.
we can do like we do for the mitral, edgeless, and go with the multi-purpose and go to the apex.
Right.
Get me?
Yes, I think that's a good approach. And you just have more control with the Gillis and more support.
And with the multi-purpose.
Yeah, because every time we kept seeing the loop in the atrium. Yeah, okay. And multi-purpose?
Here.
The other consideration for these tricuspid procedures is the relationship of the IVC to the tricuspid annulus, how far it is, and what is the offset angle, which I guess we could look at from CT. This is also relevant when we're doing tricuspid clip and TTVR. It may make it a little bit more challenging. I suspect in this case there is that relationship which may be a bit more challenging. So having a stiffer wire will help to overcome that.
Okay. Okay.
So we took the dilator out. We have the 32 wire. We're going with the multi-purpose.
Yeah.
This is how we normally would do if we are doing for the mitral. After we do the transeptal. Okay, good.
So mitral and tricuspid, anatomy-wise and devices-wise, looking you have to have same strategy.
You got to tell us on the echo what you're seeing.
What?
Very nice.
Yeah, this is it.
No more loop.
Yeah.
No, but the loop will come back when we get the wire there.
Good. Okay. Safari.
No.
The
We
safari.
have to get the pigtail, the loop we want.
Yeah.
Then only we go to a stiffer wire.
Okay.
Okay, get us the
That
pigtail.
looks like the apex to me.
I think if you go with pigtail, you'll be able to get to apex.
Yeah.
Get the pigtail.
Some ectopy.
Regular pigtail, not the
Yeah, I think you take regular 6 French pigtail, it's a
Yeah.
bit stiffer and you can maneuver.
stiffer. Yeah.
Yeah.
The long pigtail soft, and that's where I think we were struggling to get it to the apex.
Yes. But this trajectory order looks much better.
Good. Go.
Now the LAO projection for a second can tell us where the wire is, huh?
See this little bit here.
Yeah, the loop is coming back.
We may need to put flex on the agilis.
We have the
Where's the-
flex, but it's getting.
Yeah.
More flex. Yeah, good.
That's better. Gigantic right atrium.
You want a little
Yes.
further or you're good? No, this good?
It's